I would like to welcome you all to our 9th Anne Klibanski visiting lecture. And my name is Miriam Bredella, and I'm the director of the Center for Faculty Development. And I'm very, very excited to welcome you for today's session. It will feature our own Manisha Bahl, who is a radiologist, one of my colleagues here in the Department of Radiology at the MGH. And we also are expecting Dr. Yolanda Bryce, who is a breast radiologist at the Memorial Sloan Kettering Memorial Center. She has not signed up yet, but we will start with Dr. Bahl anyway. But before we begin the formal presentation, there are a few announcements. The session will be recorded and made available on the CFD website as a webinar and podcast. And we ask everyone to please complete the online evaluation form that will be sent out after the session. And for those of you who will claim CME credit, please note this slide here. There is the SMS code for attendance and all instructions and financial relationships. Dr. Bahl that she reported, and you may text this SMS code in bright red, which you see up there, EXFUL, to the phone number listed and to mark your attendance with the CPD office. And we will send you an evaluation via text, and you must complete this evaluation in order to receive the credit. Okay. So briefly, before we start, the Anne Klibanski Visiting Scholar Award was introduced by the Center for Faculty Development because the COVID-19 pandemic was disproportionately or is disproportionately affecting women with added childcare and household responsibility. And also women are less likely to be visiting professor because of challenges related to travel. So with the COVID-19 related travel ban and most grant rounds in visiting professorships being conducted virtually, we actually established an award to promote women to be visiting professor. And as to date, we have actually had 68 women, faculty, clinicians, educator, researcher, or postdocs who have shown exceptional promise as leaders in their field and have them identified as the Anne Klibanski Visiting Scholars. And they're giving their virtual visiting professor and give a lecture at the national or international institutions organized by the Center for Faculty Development. And also the scholars receive mentoring, professional coaching, and leadership training. Very briefly, the award was named after Anne Klibanski, the current CEO of Mass General Brigham. She was the former director of the CFD and head of the neuroendocrine unit, and held leadership positions at Harvard Catalyst, the Endocrine Society, and the NIH. And she was a very strong supporter and advocate for women and established the Claflin Award to support women faculty and also the MGH Backup Center. Here is the first cohort of Klibanski Scholars, where we have Manisha Bahl, our current speaker from today. And these are just some institutions where our scholars give lectures. And I want to highlight Johns Hopkins University, where our visiting speaker is from. This is the new cohort of Klibanski Scholars that we just elected. And the lecture series was actually established to support and advance the careers, not only of the women at MGH, but also of the entire US and abroad. And these lectures bring together faculty members from the institution that have hosted our Klibanski Scholars, bring it together with MGH scholars on topics that overlap both research areas. And this also fosters collaboration across institutions. So now it's my great pleasure to introduce our speakers today. Our first speaker is Dr. Manisha Bahl, and she is a breast radiologist here at the MGH, assistant professor of radiology. She received her training at Stanford and Duke, and she is a very accomplished researcher with funding at from the NIH. She has received multiple awards in writing and is actually a scholar from the journal Radiology. She has received awards from the American College of Radiology, the ACR, Radiology, and many more. And her research interests include the application of artificial intelligence. And she works a lot with MIT to improve outcomes in women with breast cancer and clinical assessment of digital breast tomosynthesis. Then we have Yolanda Bryce. She is a radiologist at the Memorial Sloan Kettering Center. She's a co-PI for a multi-institutional trial that evaluates the outcomes of combining cryoablation and immunotherapy in early stage breast cancer. She's the program director of interventional radiology, residency, and the interventional oncology fellowship programs. And she actually completed her residency here in Cambridge and Auburn Hospital, and also a fellowship at the radiology at Miami Cardiac Vascular Institute. So she is a diagnostic interventional radiologist. So without further ado, we're going to start with Manisha. She's going to give her talk, and then we will have Yolanda give her talk, and then we have questions towards the end, and you can put questions in the chat or ask them at the end of both presentations. So without further ado, Manisha, please take it away.
Well, thank you so much for that introduction, Dr. Brdella, and for the opportunity to speak today. I have greatly benefited from the Anne Klibanski Visiting Scholars Award program that you developed, and I'm so appreciative of the speaking opportunities that you arranged for me both nationally and internationally. Today, I'm happy to help welcome Dr. Yolanda Bryce, who is a colleague from Memorial Sloan Kettering Cancer Center. The topic of our joint presentation is innovations in the detection, diagnosis, and treatment of breast cancer. I will discuss innovations in detection and diagnosis, and Dr. Bryce will discuss innovations in treatment with a focus on cryoablation. My disclosures are listed on this slide. As way of background, the practice of breast imaging has transitioned through a variety of technological advances. This is an example of an early breast radiograph from the 1930s using standard X-ray equipment of the time. Since then, mammographic technology has markedly advanced. This is a comparison of negative mammograms with dense breast tissue from 1965 to the present. The first image is an example of a direct exposure film mammogram without compression. The next is a zero mammogram. Next is a screen film mammogram. And the last image is a full field digital mammogram. Today, I will discuss three recent advances in the detection and diagnosis of breast cancer, which are digital breast tomosynthesis, contrast-enhanced mammography, and artificial intelligence. Following my presentation, Dr. Bryce will discuss innovations in the treatment of breast cancer. The first advance that we will discuss is digital breast tomosynthesis, which was pioneered at Mass General and approved by the FDA in 2011. Tomosynthesis is quasi 3D mammography that consists of multiple low-dose X-ray exposures acquired along a limited arc, creating a data set that is reconstructed into a series of thin images or slices of the breast. The ability to scroll through the stack of reconstructed layers of the breast minimizes the masking effect of overlying fibroglandular tissue and improves lesion detection. The image on the left is a 2D mammogram, and the images on the right are tomosynthesis images. The small invasive cancer in the left breast is better characterized on the tomosynthesis images, particularly its margins. Prior to February 2011, patients who presented to Mass General for screening or diagnostic mammography were imaged with digital 2D mammography. Once tomosynthesis was approved by the FDA in early 2011, patients at Mass General were imaged with digital 2D mammography or combined tomosynthesis and 2D mammography. We transitioned to 100% combined tomosynthesis and 2D mammography in January 2013. We have published a series of studies on the Mass General experience of combined tomosynthesis and 2D mammography compared to 2D mammography alone. For these studies, we excluded exams performed during the hybrid period from February 2011 to January 2013 in order to avoid selection bias, since some patients were imaged with 2D mammography alone and others with combined tomosynthesis and 2D mammography during this time period. In one of our studies, we compared cancer detection rates of screening mammography for a 2-year period before the introduction of tomosynthesis to a 2-year period after complete integration of tomosynthesis. And we found that the cancer detection rates were nearly identical at 5 cancers per 1,000 exams. Although the overall rate of screen detected cancers was the same, Invasive cancer rather than in situ carcinoma accounted for a higher proportion of cancers in the tomosynthesis group. Thus, we found a preferential ratio of invasive relative to in situ carcinoma with a transition to tomosynthesis. Our other studies have explored the performance of screening tomosynthesis in women aged 65 and older and in women with a personal history of breast cancer, the performance of tomosynthesis over multiple rounds of screening, and the performance of diagnostic tomosynthesis. Our main conclusions from these studies are as follows. First, cancer detection rates are similar before and after integration of tomosynthesis, although there is a preferential ratio of invasive relative to in situ carcinomas with tomosynthesis. Second, compared to 2D mammography alone, combined tomosynthesis and 2D mammography has a lower recall rate or false positive rate, which is a benefit of tomosynthesis that is sustained over time. With regard to the first conclusion, although our studies demonstrate similar cancer detection rates before and after tomosynthesis, studies done at other institutions have demonstrated higher cancer detection rates with tomosynthesis. One of the reasons that we may not have observed a higher cancer detection rate with tomosynthesis is that the cancer detection rate with 2D mammography alone was high at 5 cancers per 1,000 exams. And the benefits of cancer detection with tomosynthesis may be reduced in practices that achieve a high cancer detection rate with 2D mammography alone. Another reason that we may not have observed a higher cancer detection rate with tomosynthesis is that we didn't include in our studies screening mammograms that were obtained during the hybrid period from 2011 to 2012 in order to avoid selection bias. However, many women in our study underwent their first tomosynthesis exam during that hybrid period. Since it's known that the highest cancer detection rate is achieved with a woman's first tomosynthesis exam, the cancer detection rate in the tomosynthesis group may have been higher than the rate in the 2D mammography group had we included all women's first tomosynthesis exams in our analysis. Our second conclusion about lower false positive rates has been confirmed in studies done at other institutions. This benefit of tomosynthesis has led to a decrease in unnecessary diagnostic imaging that may result in savings in healthcare expenses, time, and resources. Tomosynthesis is widely viewed as a better mammogram and is quickly becoming the standard of care in breast imaging. The next advance that we will briefly discuss is contrast-enhanced mammography, which is an emerging technique that uses iodinated contrast material and was approved by the FDA in 2011 for diagnostic imaging. Contrast-enhanced mammography uses a dual energy technique with acquisition of low energy images that are similar to conventional digital 2D mammography and acquisition of recombined images that demonstrate areas of contrast enhancement similar to breast MRI. Contrast-enhanced mammography was recently introduced at Mass General for diagnostic applications, such as extent of disease evaluation in women with biopsy-proven cancer. These images, for example, come from a 73-year-old woman whose breast cancer was detected at screening mammography. The patient's breasts are dense, as seen on the low energy image on the left, and her extent of disease is best depicted on recombined images from contrast-enhanced mammography on the right. Contrast-enhanced mammography has comparable performance to breast MRI, but is less expensive and may be more accessible to larger numbers of women than MRI. Contrast-enhanced mammography can be helpful in resolving equivocal findings detected on conventional imaging, in evaluating extent of disease in women with biopsy-proven cancer, and in monitoring response to neoadjuvant chemotherapy in women with breast cancer. Screening contrast-enhanced mammography could be performed as an alternative to breast MRI in women who are at increased lifetime risk of developing breast cancer. Areas of active research include contrast-enhanced mammography guided biopsy systems and AI applications. Next, I will discuss AI for breast imaging, which is a research interest of mine. Computer-aided detection, which refers to computers assisting radiologists to identify a potentially significant finding on an image, is not a new concept in breast imaging. From the late 1980s to the late 1990s, efforts were made to use quantitative analysis of mammographic images to identify suspicious lesions. In 1998, the Food and Drug Administration approved the first commercial CAD system. In 2002, the Centers for Medicare and Medicaid Services increased reimbursement for CAD use, and it was then widely adopted by the breast imaging community. Despite the early promise of improved performance, subsequent research has shown that CAD does not improve any metric of screening performance, including sensitivity, specificity, and cancer detection rate. One of the primary limitations of CAD is its high false positive rate. With this high rate of false alarms, it's likely that radiologists have learned to largely ignore the CAD markings. These early versions of CAD use a human-driven, rule-based mathematical model that cannot improve with additional inputs. Recent advances in AI and machine learning, such as deep learning-based neural networks, have opened up a new line of techniques for CAD that offer advantages over prior approaches. While traditional CAD relies on human-engineered features based on radiologists' knowledge and experience, deep learning algorithms learn the features that are necessary to classify the mammographic images as positive or negative, improve with exposure to more data, and have the potential to discover features and relationships that are currently unknown or imperceptible to the human eye. AI in breast imaging has quickly progressed from pilot and feasibility studies to clinical implementation. To my knowledge, there are currently 18 commercial AI algorithms that have been approved by the FDA. 8 of the 18 approved applications are intended for density assessment on mammography and are listed on this slide. 3 of the approved applications are intended for triage on mammography. For example, CM Triage is a software workflow tool designed to aid radiologists in prioritizing exams within a work list for compatible full-field digital mammography screening exams. CM Triage flags cases that have at least one suspicious finding, and these flags are viewed by the radiologist via their PACS works list. CM Triage is intended for passive notification only and does not provide any diagnostic information beyond triage and prioritization. 4 of the applications are intended for lesion detection and diagnosis on mammography, in which the algorithm identifies the finding and offers a prediction of malignancy risk. 3 of the applications are intended for lesion diagnosis only on ultrasound and MRI. For the lesion diagnosis only applications, the user or radiologist must identify and select the finding first. The AI algorithm then classifies it or offers a prediction of malignancy risk. I will next briefly discuss one of the FDA-approved applications in this domain of lesion detection and diagnosis. Transfera is an FDA-approved deep learning-based AI application for lesion detection and diagnosis on mammography. It provides radiologists with certain decision support tools, including traditional lesion markers, local cancer likelihood scores activated by clicking on specific areas, and a cancer likelihood score based on the entire exam. In a multi-reader study, investigators compared the cancer detection performance of 14 radiologists interpreting 240 digital mammograms with and without the use of Transfera. This is an imaging example from the article. These are mammographic images from a 71-year-old woman with an invasive ductal cancer. The abnormality, which is the cancer, is circled by the AI system with a level of suspicion score also assigned by the AI system. Without the AI system, only 4 of 14 radiologists recalled this patient for further imaging. With the AI system, 11 of 14 radiologists appropriately recalled the patient. The authors found that radiologist performance was better with the AI system as measured by the AUC, but this improvement was observed with less experienced radiologists and not with expert radiologists. Sensitivity increased with AI support and specificity trended toward improvement. Reading time per case was similar with and without AI. In a subsequent study with the same AI system, the investigators reported that the standalone performance of the AI system was non-inferior to that of the radiologists. The results suggest that this AI system could serve as a standalone first or second reader in screening programs, and that it could help radiologists with varying levels of training and experience achieve performance benchmarks. Although this AI system performs well, it could potentially be strengthened if it incorporated comparisons to patients' prior exams and to the contralateral breasts. This table lists potential applications of AI in breast imaging, which includes interpretive and non-interpretive AI. Interpretive AI includes density assessment, triage, and lesion detection and diagnosis. As we discussed, there are existing FDA-approved algorithms in each of these domains. In the future, there will likely be commercial algorithms for non-interpretive AI applications, including risk assessment, imaging controls such as scan acquisition and reconstruction, and workflow optimization. My specific research interest is in the use of AI to provide decision support, specifically to support more targeted and precise treatment options for women with high-risk breast lesions and early-stage breast cancer, and ultimately to reduce the morbidity and cost of overtreatment. A few years ago, in collaboration with Dr. Regina Barzilay and her research team at MIT, we developed a machine learning algorithm to guide management in women with high-risk breast lesions. Most high-risk lesions are benign, but surgery is typically recommended because of the low but present potential for upgrade of high-risk lesions to cancer at surgery. The resulting status quo has been overtreatment with unnecessary surgery for high-risk lesions that are not associated with cancer. The random forest machine learning model we developed included traditional features such as age and biopsy pathology results, in addition to the full text of the biopsy pathology report. Of the 335 high-risk lesions in our test set, there were 38 known upgrades to cancer at surgery. If we had chosen to surgically excise all 335 high-risk lesions, which was the standard of care at our institution at the time, then all 38 cancers would have been diagnosed, but 297 benign surgeries for high-risk lesions not associated with cancer would have been performed. If we used our machine learning model instead to determine which high-risk lesions to excise, then 97% of the cancers would have been diagnosed at surgery, and 31% of benign surgeries could have been avoided. This model could inform patient and provider shared decision-making with regard to surveillance versus surgery of high-risk breast lesions. My current work involves the application of AI to risk stratify women with ductal carcinoma in situ, or DCIS, also known as stage 0 breast cancer, and is being funded by an NIH K08 award. The goals of my award are to develop an AI tool that predicts the risk of upgrade of DCIS diagnosed by image-guided core needle biopsy to invasive cancer at surgery, and to implement and prospectively evaluate this tool in clinical practice. The AI tool will combine clinical data, mammographic imaging, and histopathology slides, and this work is currently in progress. In summary, breast imaging has a rich history of technological advances. Tomosynthesis, contrast-enhanced mammography, and AI are among the recent and emerging innovations. Tomosynthesis, which is quasi-3D mammography, has demonstrated similar cancer detection rates to 2D mammography at Mass General, but has shown higher cancer detection rates at other practices. Multiple studies, including ours, have demonstrated lower recall rates and false positive rates with tomosynthesis, which has led to less unnecessary diagnostic imaging. Contrast enhanced mammography, which uses iodinated contrast material, has comparable performance to breast MRI, but is less expensive and may be more widely accessible. The development and implementation of AI algorithms into breast imaging practices is yet another technological advance that will hopefully improve our quality and our efficiency, which traditional CAD has failed to do. There are currently FDA-approved AI algorithms in the domains of density assessment, triage, and lesion detection and diagnosis. In the future, there will likely be commercial algorithms for non-interpretive AI applications. The goal of any new technology is to provide value, and AI algorithms will need to demonstrate value through the standard metrics of increased efficiency, improved quality, and reduced costs. That concludes my presentation. Thank you so much for your attention. And thank you again to Dr. Bradella for her leadership of the Anne Klibanski Visiting Scholars Award Program and for all of her mentorship and support.
Thank you so much, Manisha. This was fantastic, and it was such a great overview about the latest technologies and where your work in AI and breast cancer detection is really, really innovative. I would like the audience to hold their questions. You can put it in the chat or wait until we're done with the second presentation, and then we have a Q&A question. So thank you, Manisha. And now it's my great pleasure to introduce Dr. Bryce from Memorial Sloan Kettering. Please take it away.
Thank you so much for the invitation to give this talk. It is a niche that I have developed here at Sloan. Other people are developing it elsewhere, and so it's not such a unique thing anymore. So, but perhaps I can show you some cases, a little information, and we can all learn together. All right, so that's my disclosure. So cryoablation is when very, very cold temperatures are used to destroy a tumor. And we typically think that tumors die around -20 or -4 or -40 degrees Celsius. And the death occurs in a multitude of different ways. So the freezing portion does create ice crystals within the tumor, and that directly kills the cell. And then as part of the treatment, we do a freezing, we do a thawing. And when that thawing happens, there is water or fluid, I should say, that then enters the cell, and as that happens, it causes the cell to expand and then burst, and that kills the cell as well and causes the ice ball that is created, that creates these ice crystals to become even bigger. And then there's also a delayed way of death, which is an inflammatory process with ischemia that results in apoptosis and macrophages and so forth. So when I think about cryoablation, I like to think that there are a few reasons that justify its use. Number one, because of increase in screening, there's an increased incidence of breast cancers that are less than 2 centimeters. So more small cancers are being diagnosed, and that is reflected in the kind of breast surgery that is being done. It used to be that large surgeries were done with mastectomy, and now just small surgeries, just lumpectomy with improved consmesis and similar recurrence rates. And there's also an evolution in assessment of margins. First, it used to be that you wanted 1 centimeter margins, then it went to 0.5 centimeter of margins, and now it's just tumor and ink for invasive cancers and 2 millimeters for DCIS. So now less parts of the breast need to be treated. And ablation results in it's less invasive, right? So there's less morbid, there's less mortality because you're not inducing, some people use general anesthesia for just a lumpectomy. At Sloan, we don't, we do it usually with just MAC, but some places they still do general anesthesia. So without that, there's less mortality and there's better cosmesis, because then you're talking about a little opening in the breast to put the cryoprobe instead of a big surgical scar. So there have been some trials that have tried to see how good cryoablation is. And there was a multi-center phase 2 trial that looked at 87 cancers with cryoablation followed by surgery. And 100% of these patients with tumors less than 1 cm in size treated with cryoablation had no residual invasive cancer on pathology examination of specimen. This was a trial that used one probe to treat the tumor. And other studies, such as this one, performed and published in 2009, has shown that you can treat larger tumors if you use a multi-probe approach. So you can put multiple probes in the breast and get better results when you are dealing with larger tumors. All right. So when we're though thinking about treating a tumor for curable intent, and maybe just starting off, sometimes it's nice to just treat the smaller tumors. So if you choose a tumor, try to choose it on the smaller side. It shouldn't have a lot of DCIS accompanying that mass, because those have shown that the tumors, it's harder to treat and get a complete ablation. And it shouldn't be too close to the skin. I'll show you methods that you can do tumors closer to the skin, but the teaching is you should try to aim for tumors that are greater than at least half a centimeter away from the skin, because you can burn the skin or get a freezer burn on the skin. So when you're planning, you can sometimes, for instance, when we're dealing with a biopsy, right, we usually try to choose the shortest distance. So this may seem more logical, but actually, when you're dealing with an ablation, you're trying to bury that big ice ball in the breast so as not to burn the skin. So sometimes a very long approach is actually what you need in order to do cryoablation, rather than going the short distance. And I make it a practice that I try never to aim towards the nipple. When you're looking at the different probes, there's different systems to use, and I don't know if one being better than the other, but what you need to pay attention to is how much of an ice ball each is able to generate. And it's not necessarily it's accurate, but at least it gives you kind of an idea of how big an ice ball needs to be generated. Now, a lot of time we focus about the ice ball not being too close to the skin surface to burn, but actually where I've gotten in trouble is that the ice ball extends far back into the probe length. And so that probe needs to be buried into the skin. So I know, according to which probe I like to use, how far and which mark I need to use to make sure that that ice ball does not track back and burn the skin. And then to protect the skin, I do a lot of what we call Hydra dissection, which is using saline infused through the needle. And I do it constantly throughout the whole procedure to separate the ice ball, which is this shadowing structure, from the skin surface. And then I use also heat packs in a sterile sleeve to try to add an additional support to decrease the burning of the skin. This is a case of a patient that was not a surgical candidate. And you see here that there's this spiculated mass. She had invasive lobular carcinoma. You see it here on the imaging. A biopsy marker is placed in the middle after the biopsy was done. And on imaging, when I'm doing it just prior to the cryoablation, I make sure that I see all the spiculations really well, because I have a rule of thumb that every centimeter of tumor gets a probe. And so I measure very well. I try to see all the spiculations. I form my ice ball. And here you see the ablation zone surrounding the biopsy clip and tumor. That's what an ablation zone looks on ultrasound. Here's a patient that had fatty breasts. So you see this tumor here in the upper outer breast. On mammo, you'll see that it's about almost 4 centimeters, but on ultrasound, it's only about 2.5, so it's underestimated. So I wanted to be able to see the whole tumor and not leave part of it behind. So what I did was I placed 2 markers on either side of the tumor that that to be able to see the full extent of the tumor. And I did the ones that you can see well with ultrasound, a Hydra mark. So here we go, we're putting the clips there at the either extent of the tumor. And then I did the ablation where I was able to see the clips, and here's the ablation zone, and it is surrounding the 2 clips. This is also another view of how it could look like on ultrasound. This was a lady, she was 94 or 95, and she had breast cancer for a while, and they were kind of watching because they didn't want to take her to surgery. Here it is, how they measured it was at least 3.3 centimeters. It was hard to measure, hard to see, but here on the ultrasound image, you see that there is decreased echogenicity on the skin surface that tells us that there is involvement of the skin with tumor. I did an ablation on her knowing that I would not get the whole tumor. I wouldn't be able to treat the tumor in the skin, but at least I wanted to debulk the lesion so it won't keep growing and growing and further involve the skin. And after the ablation, you see here on contrast enhanced mammogram that there is a little bit of residual tumor, but when you do see the orthogonal view, you see that the residual tumor is in the skin, and actually all the tumor else otherwise is well treated. This is a case, this is in breast cancer, it's actually desmoid, and I just wanted to show you this MRI in order to show you that the technique can be done under an MRI. So it's a desmoid tumor. You see these long speculations. So I wanted to do it under MRI guidance, the ablation, in order to be able to capture all the components of the tumor. And here you see, I did it just like you would do a biopsy under MRI guidance. I compressed the breast, I did the grid, I put my probes in place. Here you see them, I did the imaging, I created the ice ball. And then afterwards, I was able to see that in follow-up, there was no residual disease, and the pain the lady was having has resolved. So there are some benefits with cryoablation beyond just the immediate death of the tumor, and those are the cryoimmuno effects. And there have been some studies, some preclinical studies that have shown that cryoablation of breast tumors results in decreased metastasis. So there is a potential to try to combine this modality with immunotherapy to decrease this, the potential for metastasis or decrease the existing metastases themselves. So what it is because cryoablation, compared to other modalities of ablation, such as radiofrequency ablation or microwave ablation that uses heat, it freezes and it causes a lysis in cells, but the proteins are not denatured because they're not heated. They're just frozen, and so they're preserved. And so they can serve as antigens as that cell bursts. And when these antigens are detected and you flood the system with these antigens and the T cells pick them up and are able to react with the antigen presenting cells, they provide information to the immune system. So a lot of times it has been detected that there's not a lot of circulating DNA or circulating antigens associated with breast cancer. This cryoablation provides those extra antigens for antigen presenting cells to be able to communicate with T cells. So when that happens, then it gives the opportunity of immune therapy to do an even more potent job. So in this schema, you can see that when an antigen presenting cell has antigen and it connects with, let's say, for instance, PD-L1 and PD-1, it is able to, I should put it this way, when the antigen presenting cell with the antigen interacts with the T cell, right? There's a potential for an immune response to happen, but the body has the systems where it tries to be in balance. So it doesn't want too much immune response or too little. And one of the things that blocks immune responses is PD-L1, PD-1 connection. And when immunotherapy is added to that, it breaks that connection, and then immune response can occur. So with the combination of the antigens and the breaking of these bonds that prevent immune response, we can have an immune response. So we're doing a particular study. I won't go through the details because I know that we want to leave some time for questions, but we did do the procedure with early breast cancer. And what we saw is that these CD4 PD1 high cells, which are suppressant cells, right? So when there's a lot of PD1, that's a suppressive cells. When we combine immunotherapy with cryoablation, we saw that there was less of these cells compared to the other ways that if we treated the patient in other ways. And when that happened, there was actually an increase in effector T cells. And those are the T cells that you want that drive the immune system rather than the T cells that suppress it. There's a few differences between if you do cryoablation versus heat-based therapy. We talked about one, right? The immune response. There's some other things. So with RFA and microwave, there's shorter treatment times because you don't have to wait for that freeze and the thaw. And you can burn the skin, but you also need to worry that you can burn the pectoralis muscle. And with cryoablation, you don't need to worry so much with that. There is a need for sedation because radiation ablation is typically painful. And the proteins, as we discussed, are denatured. With cryoablation, the treatment times are longer because you have to do that freeze and that thaw. You can burn the skin. Typically, though, you do not need to be concerned of the pec muscle. There's no need for sedation. Ice ball is analgesic. And as we mentioned, the proteins are not denatured. One thing we still need to consider is a few things, right? So number one, what do we do with the axilla? Because in lumpectomies, we're doing the sentinel lymph node biopsy. So there's a question of what should we do with the axilla? Which are the patients that are the candidates that we don't need to do the sentinel lymph node biopsy? Is there something else we can do to replace the sentinel lymph node biopsy? This is one question that is still outstanding. Another one is the reliability of imaging. So in my practice, I try to get done at least one post-ablation contrast enhanced MRI or mammogram. But sometimes the literature has shown those are not always sensitive, and the literature has shown that sometimes there's still residual disease, even though the imaging looks okay. And then there are some patients that are not eligible for either modality. And how should we follow those? Should it just be a mammo and ultrasound? Is that good enough? And so these are the outstanding questions that need to be answered as we perfect and move towards this imaging being more pervasive in treating our patients. Thank you so much.
Thank you so much. That was fantastic. And as a musculoskeletal radiologist, I'm using both cryo and heat ablation. So this was really expanding my horizon. So thank you. So we're now going to start the question and answer session. I'm so excited and honored to have Tash Katapuram, who raised her hand, who was actually one of our residents. And she did a breast IR and IR fellowship, and her mother is one of our very esteemed musculoskeletal colleagues. So Tash, please unmute yourself and ask your question. And maybe we can see your picture. That would be great.
Hi, I'm sorry, you cannot see my picture on your computer. I apologize.
No problem.
But Drs. Bahl and Bryce, so great to see you guys. I got to meet both of you during my residency and fellowships. So this was super exciting because I'm fellowship trained in both breast and in IR. So it was great to combine both my fellowships. My question is actually for Dr. Bryce. How do your surgeons feel about cryoablation? And the reason I'm asking is I'm more private practice, community-based, rural radiologist, and I really feel like this would be amazing for our patient population because we don't necessarily have dedicated breast surgeons. And, a lot of the places where I work, it's hard to recruit people. But I also feel like our current surgeons might not be happy if we introduce them, as it could take away their business, their RVUs, things like that. So that's my first part of the question. And the second, if you know the answer, because this is always a big deal in private practice and community, is how to budget for potentially introducing this technology. Is insurance covering everything? And what are the costs to kind of consider with implementation?
Okay,
Thanks,
so
Tash. Before you answer, could you stop sharing so we can see your face and we can see each other? Thank you so much. Great.
Thank you. Sorry about that. Okay, so for the first question, what I have done is that I have tailored my practice to be patients who are not eligible for surgery or who refuse surgery. So I don't think I'm really encroaching on the breast surgeons. And I think with time, maybe will be that surgical candidate patients will be done here at Sloan, but mostly I have started my journey with just patients that are not surgical candidates. So they were gonna just treat them with just some hormonal therapy and see if it treats them and if that's good enough, or the patients that are adamant after consulting with a breast surgeon, adamant as to not wanting to proceed with surgery. The second question is a good one. I was just talking to my colleague about it. I know that I haven't had a procedure yet that has been rejected by the insurance, because I know I would have heard about it, because then I have to do peer-to-peer and so forth. But I'm not sure what IR does to have these be okay with the insurance. The modality I use is not FDA approved necessarily for breast cancer. But I don't know, I'll be honest, I can, Taj, I remember you from residency. If you, I'll like, I'll give you my phone number, I'll put it here in my chat, and I'll try to find out what happens, because I don't know. But I know that they're not rejected.
Great, thank you. Does that answer, Tash? You wanted to know about the budgeting, correct? How you budget for this? And
yeah, so
right.
That's what I'm saying. I'm not sure
okay,
about. Not sure about all that is done behind the scenes with billing, because obviously I'm in an academic practice, so I don't deal a lot with billing. But I just know that the insurance companies have not rejected it. For budgeting, you need a machine. I guess I can tell you that you need. What do you use in your regular IR practice, Taj, for just any kind of cryo?
Well, so right now I don't use cryo in my practice, just where I'm located. I don't do the non-breast work at my current practice. So
yeah, but I'm saying, like, for any cryo anywhere in the body, do you have a modality?
So CT.
Okay, but I meant like your cryo machine.
Oh, I don't know, because it's been a long time. I haven't done cryo in years.
So
I don't know what they use here at the hospital.
So you, honestly, any cryo machine that is there at the hospital, just use that. You don't need to get one of those fancy office-based. You don't need, so for startup, you just need any cryo machine. I don't know if it's okay to say, I know we're not supposed to say the
and you say whatever you want. It's okay.
Well, I'm just gonna say I'm not vouching for them. It's just what I use at my institution, because that's what was available to me, is Galil. And everyone who's familiar with Galil knows that it's used for kidney, it's used for liver, it's used for other soft tissue in the body. It's not unique for breast. In fact, it's not marketed at all for breast, but that's what I use, because that's what I have. So any cryo machine, that's what you can use. And I do all my procedures except for a few under ultrasound.
Great, thank you. Other questions? You can raise your virtual hand, you can unmute yourself, you can put the question in the chat. While you're doing this, I have a question for Manisha. I'm so intrigued by your AI work, and I think this is probably going to be the future in all modalities. And I think breast is a little bit ahead of the game of the field, because as you all know, and Yolanda, I'm sure it's the same at Memorial Sloan Kettering, we're reading more and more and more, and the radiologists are expected to read more MR, CTs, and I think probably AI is going to be our savior. That's going to help us to stay productive when reimbursement goes down, and will just assist us so we can read even faster. So I just wanted to know your, and also Yolanda's, your experience with using AI in clinical practice. Is it helping?
I wish there was my very brilliant AI colleague was here. I cannot speak to this at all.
You don't use it at all?
I don't use it. I don't use it. So I honestly cannot speak to it. I know that my colleagues are working on it and developing it and doing amazing work that I'm sure soon it will enter the clinical space and I can use it, but I have not.
Manisha, are you using it regularly in clinical practice or more for your research?
More for research. We're currently using the traditional CAD for mammography, which is an AI-based. So most of my experience with AI is from a research perspective and in a consulting role that I have with a medical AI software company. But I think it shows a lot of promise. The best for at least the best performance seems to be achieved by combining radiologist and machine together. So I think it is unlikely to replace us, but certainly to help us. Dr. Langlotz, who is a radiologist at Stanford, has said it well that AI won't replace radiologists, but radiologists who use AI will replace radiologists who don't.
Yeah, I think that is probably what's going to happen. Thank you. It is exactly 6 o'clock, and I would like, if there is no question, I don't see anything here in the chat, I would like to thank you so much, Manisha and Yolanda, and very nice to meet you. This was really, really eye-opening. It's such a great presentation. So thank you so much. And I also would like to thank the audience. We had a great turnout here at 5 p.m. So thank you all for attending. And I wish you all a good night. Thank you.